Hey everybody, this is Tom Tolbert, Pulmonary and Critical Care Fellow, and I want to talk today about Acute Respiratory Distress Syndrome, or ARDS, and Ventilator-Induced Lung Injury, or VILI. And this is going to be a bit of a rush job because we're right in the middle of a pandemic. I'm not going to be able to correct this. You might hear my dog in the background. I'm going to stumble over my words a little bit more than usual. But I thought I should try to get this out as fast as possible given how COVID is sort of overwhelming our system, and all of us are going to have to become experts in ARDS and VILI. I'm going to go through 4 things as sort of a basic outline: how ARDS happens, the Berlin definition, or how we define ARDS clinically, VILI, ventilator-induced lung injury, and the 4 traumas that VILI causes, like traumas to the respiratory system, to the lungs. And then ventilator strategies that try to avoid making a bad situation first. If you have somebody with ARDS, with ARDS, the whole point is to not make them worse with your ventilator, to support them while their lung heals. So you want to avoid ventilator-induced lung injury while you're supporting them through their respiratory illness, and that's what we're going to talk about. So the basic pathophysiology of ARDS is as follows. The thought is that either something directly injures the lung, and that's usually pneumonia or aspiration in the case of medical lung disease. In our current epidemic, pandemic, COVID is thought to cause direct injury to the lung because it directly infects lung epithelial cells. So I think COVID would almost certainly be in the direct injury pathway of ARDS. The other pathway, of course, is the indirect injury, which is, instead of going through the airways and down into the lung epithelial cells, comes from the rest of the body through the bloodstream and directs and injures the endothelium, so like the blood cells. And that's usually sepsis or pancreatitis, again, in medical lung disease. I'm not as familiar with ARDS from trauma. Whether that's considered more direct or indirect, you'd have to talk to somebody with more experience in that. Most of what I deal with is medical lung disease. And I will say that COVID we've observed this kind of late stage phenomenon where these patients get this kind of cytokine storm, and that would be akin to like a sepsis or an HLH or even like an iris or something. And that could be a cause of like further indirect injury to the lung. So sort of hard to say whether for sure COVID is a direct injury or indirect injury to the lung. It doesn't really matter very much clinically, and it's probably a little of both. Maybe early on there's some direct injury, maybe later there's some indirect injury as you get this like hyperinflammatory syndrome. But this is the paradigm. So if you get either alveolar damage from that direct injury or endothelial damage indirectly, what happens is that you get leaky capillaries from the endothelial damage, and that causes interstitial flooding. You get fluid that comes out of the bloodstream and leaks into the interstitium, so you increase the interstitial space. You increase the distance between the endothelium and the epithelium of the lung. At the same time, because you've had alveolar damage, you get barrier breakdown. And barrier breakdown, along with interstitial flooding, leads to airspace flooding. So now you've not only got fluid that shouldn't be in the interstitium, the fluid is now leaking into the airspace itself. And this leads to decreased surfactant activity. If you have airspace flooded, the surfactant just isn't as active, and there can be injury to type 2 pneumocytes themselves, so they can't produce surfactant. And because you have flooding of the interstitium, you have stiff alveolar walls. And all this stuff together causes collapse of this airspace, and we call that consolidation. It's like consolidation literally means like a bringing together, right? So I guess think of it, you're bringing together the walls of the lung, or you're collapsing the whole tissues of the lung onto themselves. And that's what you see when you see like a CT scan and everything's whited out in the lung. That's consolidation. The big point here is that this airspace is not getting any ventilation, right? If it's collapsed like this, no air can get in here, but it's still getting blood flow. Therefore, there is a low ventilation on top here. That's V with a dot on it, or ventilation. And there's still a preserved blood flow, or Q. So this is a low VQ unit. So any blood that passes by this unit does not get oxygenated and ends up in an admixture with the blood from healthy units when you get back to the pulmonary veins, and it causes a decrease in the PaO2 of the systemic blood. This is called shunting, and shunts or physiologic shunts, as in the blood's going on the pathway it's supposed to go on. It's not going through an anatomic shunt. It's still going through the appropriate anatomic parts of the lung. It's just those parts of the lung aren't working. So you have shunting of blood, physiologic shunting of blood, causing this admixture that decreases oxygenation. And that's the major problem in ARDS, is that there's shunting of blood. And this, of course, leads to low PaO2 in the pulmonary veins, which enter the heart and then go out systemically. And, of course, a low P to F ratio, or PaO2 over the FiO2, P to F. That brings us to the Berlin definition, and this is from, I think, 2012 in JAMA. There's 3 components to it, and then there's a severity score. So there's 3 things you have to say that somebody has ARDS, and then there's a way you say how severe the ARDS is. So it has to be acute onset, and so that's within 7 days of a trigger. A lot of times we say if somebody aspirates, you can identify the timing of the aspiration, or if somebody gets pancreatitis, you can sort of kind of identify when the pancreatitis started or the sepsis started. Within 7 days of that, if they develop this heterogeneous lung injury with hypoxemia, that's consistent with ARDS. Sometimes you can't identify the trigger, so we say within the start of respiratory symptoms if we can't specifically identify what the trigger was. The imaging has to be consistent, and I don't think it's really helpful to get too heady or fancy about this. If you see somebody with really bad hypoxemia and they have evidence of parenchymal lung disease on either a chest x-ray or a CT, that is consistent with ARDS. It's never been helpful to me to have these long conversations about like, well, is this truly like ARDS because it's not as bad as we think? I just think like it's a yes or no. Do they have bilateral parenchymal lung disease? And if they do, and they're really hypoxemic, I think that's consistent with ARDS. It shouldn't be like, say, bilateral pleural effusions. That's not ARDS. It has to be parenchymal lung disease. And it shouldn't be like bilateral pneumothoraces, and it shouldn't be bilateral mucus plugging or something. It's got to be in the meat of the lungs, in the parenchyma. And lastly, they can have heart failure. You can, of course, have ARDS and heart failure. It's just that the heart failure alone cannot explain the extent of the respiratory failure. So if somebody has like a slightly elevated wedge pressure, like if you were to do a swan on them and you found that their left ventricular pressures were high, their left atrial pressures were high, that can't explain the extent of their hypoxemia. So this, of course, can get confusing, but we do see patients where it's like these patients look like they have ARDS, but maybe they also have some heart failure going on at the same time. It's just their heart failure isn't bad enough to explain their ARDS. And lastly, this is the severity scoring. This is just kind of something you have to memorize, have in the back of your head. Mild ARDS, you have a P to F. That's that PaO2, or the pressure of oxygen in the artery over the FiO2, or how much, like the percentage of oxygen you're giving them. And that's like expressed from 0 to 1. So 100% would be 1, 10% would be 0.1, right? P to F of 200 to 300 is considered mild ARDS. Moderate is 100 to 200. And severe, we say less than 100. Don't get caught up on like thinking these are really set in stone, because there are trials where they define severe as like less than 150. So to be honest, sometimes clinically we think of this as not so much a moving target, but kind of a malleable one. Because like PROSEVA, which was the proning trial, it defines severe ARDS as like less than 150 P to F. So when somebody gets to 150, I'm like less than 150, I'm no longer saying with gusto that they just have moderate ARDS. I'm kind of thinking in the severe ARDS mode, depending on their trajectory. Something I like to point out when I'm talking about ARDS with people is there really is no specific treatment for ARDS. ARDS is parenchymal lung injury leading to significant gas exchange deficiencies, right? If there were a drug we could give somebody that would just make that parenchymal lung injury go away, that would be kind of like a specific ARDS treatment. But we don't have that. Instead, the way we manage ARDS is largely supportive, and this is what I mean. To treat ARDS or to manage ARDS, you have to treat and avoid the risk factors or the things that you think caused ARDS in the first place. So you don't want them to get more aspiration. If it was an aspiration event, you want to avoid that. You treat any pneumonia with anything you can. So in the case of COVID, we don't know what the treatment is going to be yet, but if you think there's a bacterial pneumonia on top of the COVID, you give antibiotics. And you also try to treat any causes of indirect injury like sepsis or pancreatitis. And then at the same time, you have to protect the good lung. So this is all the lung you have left. A lot of the lung is diseased, and you just can't really do much about that. You have to wait. That's going to take time to heal. In the meantime, you have to support the patient's gas exchange using the good lung, and you don't want to hurt the good lung because that's all you've got left. If you start hurting the good lung with your interventions, you're going to go from a bad situation to a worse one, right? So that's where avoiding VILI, avoiding ventilator-induced lung injury comes in. Anything that causes high mechanical stresses, so like high physical, like literally pulling and pushing and tugging on the cells and the fibers of the good lung, will lead to potential injury to the good lung, and that's what you want to avoid. The other thing you want to avoid is excessive fluids. So any fluids you give the patient has the potential to raise their filling pressures, the filling pressures in their heart. So if the filling pressures on the left side of the heart go up because you are given fluids, that increased pressure, like increased left ventricular end diastolic pressure, increased left atrial pressure, is going to back up into the lungs. And those good lungs may not be quite as good as perfect, right? So even though they're good, even though, I'm saying they're good with finger quotes, there might still be some leakiness because these are sick patients. And if there's any leakiness, they're not going to be able to tolerate higher back pressures inside the bloodstream. So you want to avoid flooding the good lung with fluids. And that's why in my practice, we tend to say, use a conservative fluid management strategy. Don't give fluids unless it's absolutely necessary. And even maintaining a negative fluid balance with diuretics is appropriate a lot of the time. Getting these patients to, pee more because you want to keep their lungs nice and dry so that you can use this good lung unit for gas exchange. And at the same time, like I said, there's no specific treatment for the parenchymal lung disease, except in the case of, pneumonia, you're giving antibiotics. But for the most part, you have to let the patient's immune system and their natural healing abilities clear out the lung injury while you support the patient with all your treatments here, all your management here. Now here we come to the biggest principle in ARDS, and that's low tidal volume ventilation. And the reason we want a low tidal volume is it goes like this. So let's say I have 2 healthy lung units here, okay? And I give them 500 mLs. I'm just making this up. These are healthy and compliant. That means they're able to stretch out without creating a lot of pressure. So they're stretchy lung units. A healthy lung is a stretchy lung. It's like a balloon. If I give these 500, since they're both equally stretchy, that 500 is going to split into both sides, and you're going to get 250 on each side, and these stretch out just as much as they're supposed to, not too much, too little, and you get nice ventilation that way. Now, if I disease one lung unit, okay, so this lung unit is now consolidated. It's that low VQ unit where there's shunt through it. It's stiff, so to open it up, we would need a lot of pressure. Okay, so it's a very stiff lung unit, and I'll just be frank, there's really going to be no way to open a lung unit like this that's full of fluid and pus and whatever. So if I give 500 mLs, the same as I did before, to these 2 lung units, what's going to happen? Well, most of the volume is actually going to go into the healthy and compliant lung unit because this one's stretchy, and so it accommodates that volume, while this one is stiff, so it can't really take any volume at all. And look what you've done now. You've stretched out this healthy lung unit. Instead of filling it nicely, you're like tearing it to pieces just by stretching it out. And this is basically alveolar capillary membrane damage just from stretching this lung unit out too much, from filling it with too much volume, and that's called volutrauma. And volutrauma is what we're trying to avoid when we're treating somebody with mechanical ventilation in ARDS. We don't want to overinflate the good lung. We have to protect the good lung. So we don't want to give more volume than is necessary to just fill the good lung. We basically have to give up the bad lung, fill the good lung with just the right amount of volume necessary to avoid stretching it out like this. At the same time, if you do stretch out the good lung like this, what you can have is compression of the good lungs vessel here. So this was a nicely oxygenated blood vessel, right? But if you compress this nicely oxygenated blood vessel, you increase the pressure here, and so blood is going to shunt more through this side where the pressure is still kind of low, right? And that's going to actually worsen your gas exchange, and you're going to have even more hypoxemia. Further, since you've done that, you've increased the blood flow through the bad lung unit, the diseased lung unit. So this is even worse VQ match, right? Even lower VQ match. And at the same time, you've overinflated this lung unit. So now this is like you're creating dead space here because this is higher ventilation than blood flow, right? You've overinflated it, you've decreased its blood flow. So now you've got some serious VQ mismatch, right? Shunting and VQ mismatch all at the same time. So how do we avoid all this? How do we avoid volutrauma? How do we avoid worsening gas exchange? It's pretty simple, really. And if you can remember only one thing about ARDS management, it's this. When you're trying to determine the tidal volume you want to give, always use 6 milliliters per kilogram of ideal body weight, okay? The numbers can range from 4 to 8, but 6 is an easy number to remember. That's your target. That's how much tidal volume you want to give with each breath in somebody with ARDS, and that is to protect their good lung while their bad lung has time to heal. Okay. Note that ideal body weight is based on the patient's height, so you have to get the nurse or the PCA or whomever to measure the patient's height in order to calculate this. There are equations to calculate this. You can look online, you can just plug in the numbers, but you need to figure this out. You can't use the patient's actual body weight because they don't line up. The short of it is that just because you gain weight doesn't mean your lungs get bigger. Your lungs are really, the size of your lungs is really based on your height. So you need to know the patient's height. You use the patient's height and sex to calculate their ideal body weight. You multiply that ideal body weight by 6, and that gives you the tidal volume that you want to aim for with each breath. So in the case of this, example we've been working with here, so this diseased and stiff lung and this healthy and compliant lung unit, if we give 250, right, so now 5's going to the diseased and stiff lung, and only 245 rather than that 490 is going to the healthy and compliant lung, and we have inflated this good lung unit just enough and not too much. Let's talk about plateau pressure. I'm sure you've heard the term if you've worked with ARDS at all. Plateau pressure has come up. Your lungs sit inside your chest, of course, and are surrounded by pleura and a pleural space, chest wall, diaphragm. The gradient in pressure between your alveolar space, or the difference in pressure between your alveolar space and the pleural space, is called the transpulmonary pressure, okay? And if you overinflate this lung and create a big pressure between the alveolar space and the pleural space, that's a big transpulmonary pressure. What can happen is that at any weak points in the alveolar space and in the airway, anywhere that can't tolerate this big transpulmonary pressure can pop open, just like a balloon has a weak point that eventually breaks open and pops the whole balloon, right? And that will lead to pneumomediastinum and pneumothorax, so air in the pleural space or air in the pneumomediastinum, like surrounding the heart and the major vessels in there. And that's the definition of barotrauma. Pneumomediastinum and pneumothorax, if those occur during mechanical ventilation, during ARDS, that's called barotrauma. And that's why what we're trying to avoid by keeping our plateau pressures as low as we can. Our goal is to keep plateau pressure at less than 30 centimeters of water pressure. In order to check that we've done that, we go up to the ventilator and say I have a ventilator here that is showing a high peak pressure at 40 centimeters of water. what I can do is I can do an inspiratory pause. And what that does is it delivers the breath and then just holds the breath inside the patient. It doesn't allow any of the flow to come back outside of the patient. So now the patient's lungs and chest wall are inflated, and I can check how much pressure it's creating to inflate the lungs and the chest wall. So in this case, in this first case here, we have a high peak with a normal plateau pressure. So you see this got up to 40. And what this means, this spike means that the high pressure is coming from the airways and not from the lungs and the chest wall. So this would be a case in which the plateau pressure is fine. The reason the pressure is high is not because of the plateau pressure. But here we have a high peak with a high plateau pressure. And this means that the high pressure is coming from the lungs and the chest wall. We've inflated them, and by inflating them, we have created this high pressure, higher than we want it to be. So if we see like a plateau pressure of 35, we need to make some adjustments to get it back down to 30. I want to discuss this point in just a little bit more detail. If you have a patient who's on a ventilator, and let's say they're getting 20 centimeters of PEEP, right? So this is PEEP here, and with each breath their peak pressure hits 35. What you know is that between 35 and 20, that's 15. It's taking 15 centimeters of water pressure to get air into the whole respiratory system. You don't know yet whether it's the airway or the lungs and chest wall that are creating that 15, or how much of each is contributing to that 15 centimeters of water pressure until you do the inspiratory pause. So now let's do the inspiratory pause. What we see here is we have a plateau pressure of 30, okay? So PEEP right here was 20. The driving pressure is the pressure between the PEEP and the plateau pressure. So plateau pressure minus PEEP, 30 minus 10. The driving pressure here is 10. Or 30 minus 20, sorry. 30 minus 20, driving pressure here is 10, okay? The pressure between the peak pressure up here, this 35, and the plateau pressure is the airway pressure. So airway pressure equals the peak pressure minus the plateau pressure, 35 minus 30, and that's 5. So now that we can say that 5 centimeters of water pressure coming from the airway and 10 centimeters of water pressure are coming from the lungs and chest wall. Just to hammer this home, so this is all airway. Everything, all the tubing, including the ET tube, as well as the patient's trachea, all the way down into their respiratory bronchioles, is considered airway. And in order to overcome the resistance pressure to get flow down that airway, that's where the airway pressure comes from. So it took 5 centimeters of water pressure to push the tidal volume down through all of this, okay? That's what this is saying here. Driving pressure, on the other hand, is the pressure it takes to inflate the lungs and the chest wall. And that's like the stiffness pressure. So if the lungs and chest wall are super stiff, it takes like a really high driving pressure. And if the lungs and chest wall are not stiff, if they're, not floppy, but elastic, I guess, then it's going to take a low driving pressure. This example is kind of adapted from a real-world example of a COVID patient, and apparently these COVID patients, when they have ARDS, they tend to be pretty PEEP responsive, and they tend not to have very high driving pressures. There are a lot of reasons that could be, and it's just an observation right now. I don't know how true it's going to be for COVID patients in general, but I would not be surprised to see COVID patients being on high levels of PEEP, so like, between 18 and 22 of PEEP, while having like maybe still not a very high plateau. Like even though you have them on that high PEEP, you could keep that plateau pressure less than 30 because they don't require too much driving pressure. Their lungs and their chest wall are not actually that stiff. And since I brought it up, let's talk about PEEP and what PEEP actually does. So if you don't give enough PEEP, if you say your PEEP was 0, right? You don't give enough positive end expiratory pressure. With each breath, what you're going to do is for a lot of lung units, including potentially healthy, good lung units, you're going to cause them to open and close like this, right? So they're going to collapse, open up, collapse, open up. And that's thought to cause something called atelectotrauma or atellect trauma, which is like just the shear stress of the walls kind of sticking together and then pulling apart over and over again. And that's thought to maybe lead to injury to the good lung units, so you want to avoid that. You avoid that by giving PEEP. If you give enough PEEP, you keep the good lung units open without stretching them out too much. So you keep them from closing up again. If you give too much PEEP, what happens is like the same thing with Volutrauma and Barotrauma. You stretch those good lung units out too much, and you can actually cause more shunting through the bad lung units. So that can lead to worsened gas exchange. On top of that, because you've increased intrathoracic pressure with a lot of PEEP, what will happen is your cardiac return, or how much venous return goes into the heart, will go down, and therefore your cardiac output will go down, and therefore your blood pressure will go down, and you're risking like hemodynamic collapse. So you have to watch both whether you're worsening any oxygenation and whether you're worsening hemodynamics anytime you go up in PEEP. What I say is that you want to go, let's say if you have somebody who's on like a very small amount of PEEP, if you increase the PEEP and their FiO2 requirement goes down or their oxygenation goes up, I would call that PEEP responsive. And I would say that you could make an attempt to increase the PEEP a little bit more. You have to make very small changes and wait to see what happens. But if you make very small changes, you can probably increase the PEEP until you stop seeing the FiO2 requirement go down, or you stop seeing their SATs go up. And if you get too high, you're either going to see that, you're going to see that their gas exchange worsens, or that you're causing hemodynamic compromise, or both. And at that point, you need to back off, and you can't increase PEEP that much. So we talked about Volutrauma, Barotrauma, and Atelectrauma. The last one is Biotrauma. That's the fourth trauma. And this one's, I guess, probably the most theoretical and kind of the hardest to come up with a specific treatment for, or a specific way to avoid. What it is the idea is that by stretching out the lung over and over again and hurting those cells, the lung releases inflammatory mediators into the bloodstream. And these inflammatory mediators reach other organs and cause systemic inflammation, or biotrauma, and that causes MODS, or MODS, or the multi-organ dysfunction syndrome, which is often the thing that actually kills patients with ARDS. A lot of the time, patients with ARDS don't die from horrible gas exchange. They actually die from all of their organs failing, and this is thought to be one of the mechanisms, is that just by injuring the lung itself, you release these inflammatory mediators and cause inflammation everywhere. And the best way to avoid that, as far as I know, is really just to avoid the other traumas. So don't cause Volutrauma, don't cause Barotrauma, and don't cause Atelectrauma, and hopefully you won't have so much inflammatory mediator release, and you won't get the systemic inflammation. I'm not really going to talk about steroids here, because steroids, in theory, is kind of a way to avoid this biotrauma, right? Because steroids are supposed to decrease inflammation. There's a recent article called ARDS, came out in February this year, and I'm not very familiar with it, but it had some pretty impressive results. I will say that right now it's pretty controversial. We don't know whether treating COVID patients with steroids or not is going to be helpful, and it probably has a lot to do with when you time the steroids, because you don't want to give steroids too early and suppress the immune response to keep the virus load down. And you don't want to give it too late when they get this kind of hyperinflammatory syndrome that causes these patients to crash. I would say the jury's still out, and I can't say either way when or how much, or whether we should even at all give steroids for COVID patients. So this is a summary. This is obviously the most boring slide, but I tried to put this as kind of a card, just to summarize everything here that in theory you could print out and put in your white coat if you're so inclined. But how does ARDS happen? It's either indirect or direct lung injury that leads to alveolar or capillary membrane damage, and that causes pulmonary edema and collapse and consolidation of injured lung units, which leads to VQ mismatch and principally shunting. The Berlin definition is lung injury within 7 days of a trigger or of symptoms that causes pulmonary opacities, bilateral pulmonary parenchymal opacities on imaging, and is not just from heart failure, and includes a severity measurement of a low P to F, a low PaO2 over FiO2, at least below 300. When you are supporting these patients with the ventilator, you want to avoid the 4 traumas of ventilator-induced lung injury. You want to avoid Volutrauma, Barotrauma, and Atelectrauma with your settings on the ventilator. And if you avoid all of these, hopefully you can avoid biotrauma. To do this, you want to give them, and this is the absolutely most crucial point, you want to give people for tidal volume less than 6 milliliters per kilogram of ideal body weight. To avoid the barotrauma, you want to keep your plateau pressures less than 30 centimeters of water. You want to give the right amount of PEEP to keep the good lung units open and not collapsing, but not too much PEEP because you don't want to overstretch those good lung units. And like I said, the best way to avoid biotrauma is to avoid these other traumas. Thanks a lot. If you have any questions, any comments, please let me know. Appreciate you watching.